see that our captions are working, so that's excellent as well. Hi, folks. Thank you all so much for joining us today. Hopefully you are here for our 11:15 Medicaid waiver all come webinar. If so, you're in the right place. We have a lot of people actively joining right now. So this is the part of the hour where you all get to hear me talk a little, get us oriented, and just warm up for our real content that will come very soon. Um, my name is Jessica Diaz. I work for the Oregon Health Authority. And Damaris, if you can go to the next slide, then we'll talk a little bit about Zoom before we dive into our presentation and open up for questions. So we are using Zoom today. There are a lot of great tools built into Zoom to help us have a good and interactive time today. Um, the first tool is using our chat. So if you look at your toolbar, it's for most of us, it's on the bottom of our screen. There is a button that says chat. It has two little thought bubbles or speech bubbles. And if you use that chat, it's a great way to let us know that you have a question, a concern, a comment without interrupting the flow of the content that we're giving. It also is great because we will be saving this chat and we'll be able to refer back to the thoughts that people have shared if there's anything that we aren't able to get to in this webinar today. You also have a tool which is I'm seeing not on this screenshot, but it might show up right next to the React as a little hand, and it says raise hand. Doing that is a great way to get our attention for us to pause, and then we can call on people. And it's really helpful if everyone stays muted other than when we're having that interactive time, just because we have 100 people here. So that's a lot of people. And so far we've had a really great a great vibe, I will say so far. People have been very respectful. People have had great questions, great things to share, and we're looking to continue that experience for all of us. We are recording today, so if there is anything that you want to refer to later or you want to send to a colleague, then this will all be available on our public website. And so you don't have only this time to interact with us and to learn. There will be more opportunities, and you can also see all of our previous recordings up on our website as well. Last but not least is we have a live captioner here today, and so if it is helpful for you to see a transcript or to see those captions, there is that sort of a rounded rectangle with two C's in it. It should say show captions, and if you click that, you'll be able to see captions on your screen right under the presentation itself. So now that we've gone through the Zoom meeting tips, Damaris, if you can take us back to the title slide for a second, then I can be a professional person starting this meeting, and then we can get into our content. Perfect. Looks like we're starting to stabilize with our participation as well. All right. Hello, everyone. This is the All-Come webinar for January 2025 for Oregon's 1115 Medicaid waiver. Thank you all so much for joining us. We have a lot of great things to go over today, and so I'm going to get right into it. Tamara, so we can skip past the Zoom pieces to our agenda. Perfect. So today we are going to start the way we always start, which is making sure we're all on the same page for what our 1115 Medicaid waiver, what that means, what we're here to do, before getting into content that is specific to this webinar. We're going to talk about the Benefit Update Project, as well as give an update on community capacity building funds and leave time for question and answer at the end. I'm not sure, we might pause between the topics since they are fairly different as well, but just know, please continue to use the chat, use a hand raising functionality, and so if anything comes up where we can be more interactive, we will make that happen. With that said, it is time for me to hand it off on the next slide to Steph Jerem, who's our main presenter for today. Take it away.
Thank you, Jessica. Hi, everybody. Steph Jerem. I use she, her pronouns, and I am the director of the Office of Health Policy at OHA, and I am currently serving as the 1115 Medicaid Waiver Policy Director. I'm going to start today by talking about our general Medicaid waiver background. So if we go to the next slide, please. This is just our standard level setting. We're here to talk about the Oregon Health Plan. I'm actually going to talk about it a little bit more in depth later as well. But the Oregon Health Plan is what we call Medicaid in our state. Medicaid is our nation's public healthcare program. And it is free. It provides free healthcare coverage for low-income individuals, children, teens, adults who live in Oregon. And you can apply at any time of the year. Next slide, please. Our overarching conversation is about a Medicaid waiver. And so in order to get Medicaid funding, states have to follow certain federal rules about how you use Medicaid, how you support services through Medicaid. But states can ask to change those rules. And you go through a process with the federal government to formally change the rules, and those changes are called a Medicaid waiver. They're 5-year time periods for us to kind of test out new ideas. Next slide, please. So the key changes are really grouped into 2 areas. So this is what we're testing. We're in the middle of our current waiver time period. The first is expanded Medicaid coverage, so meaning more people are enrolled for longer. We've done that through continuous OHP eligibility and enrollment for children up to age 6. Everyone else gets 2 years of continuous enrollment, as well as coverage for young adults with special healthcare needs. We talked about that in one of our last webinars, and that launched January 1st. The second key changes of our 1115 waiver right now are expanded Medicaid benefits and services. And so we've spent lots of time talking about that first bullet here around health-related social needs supports. There is a limited set of services for people in a carceral setting. We also talked about that in the last few months, 90 days prior to release. There are tribal traditional healing practices, new appeals systems, and the last line is what we're actually talking about today. Some currently uncovered services that will become covered. So let's jump into that next slide. And apologies, I'm getting over a sickness, so I have a cough drop in my mouth. We're here to talk about the Benefit Update Project. It's also known as BUP. And we have lots of staff here today to support in the chat as needed. This is going to be pretty dense information. There's a lot to learn about this, and it is complex. They've done a really good job trying to make this as straightforward as possible. But we appreciate you all being here to learn about it as well. So we're starting with kind of our most important takeaways. If you get nothing out of today's presentation except what's on this slide, that's a great start. So the first is that we are here to talk about a project that we are going through to update how OHP benefits. And so benefits are the actual services that people can get through Medicaid. How those are organized so that everything that is medically necessary for somebody and appropriate can be covered through Medicaid. So it's mostly an administrative change rather than a change to how those services are delivered. Nothing is changing at a doctor's office. Nothing is changing about the way that most members will get their care. It's really kind of this back end, behind the scenes administrative change. No members are going to lose services as a result of this transition. And some services that aren't covered today will actually be added to the benefit package. So these are really clear takeaways. These are examples of things would be like medications to treat some allergies are getting added. Medications to support or services to support fibromyalgia will be added. And we're going to go through this in more detail. But this is, there's a lot of changes to this that are, that I think people are recognizing is a change to how we've always done things in Medicaid for the past 30 years. And so we really want to make sure that folks are understanding what this means and why it's happening. Okay, so next slide. I'm going to talk a little bit about how Medicaid works in Oregon currently for the next few slides to be able to talk about where it is and then where we're going. So before we dive into more details about the Benefit Update Project, the BUP, we want to quickly review some of the basic information. So as I said previously, Oregon Health Plan, or OHP, is the name of the Medicaid program in Oregon. So this is the free healthcare coverage for people in Oregon who are eligible. It's based on income level for the most part. Medicaid covers things like healthcare services such as doctor and hospital visits and many other things, labs, x-rays. It is, a health insurance program in a lot of ways. A very unique thing about the Oregon Health Plan is our Health Evidence Review Commission, also known as HERC. So HERC is a group of physicians and providers and members, and they review what is known about potential healthcare services, and they make decisions about what should be covered or what should not be covered, and where it fits within the Oregon Health Plan benefit package. So, should this service be covered for this disease? Should this medication be covered for this disease? That's the type of work that the HERC reviews. It's a public commission, and they look at the evidence and they really try to understand how this fits for most people and what their recommendation is for including it as a service that's covered. The HERC then produces this document called the prioritized list. And so all the services that they've reviewed are arranged in order of importance for the Oregon Medicaid population. Oregon has had a special waiver that has allowed us to use the list. We're the only state in the country that has used it. This waiver is ending at the end of 2026. And so that is really why we're here to talk about the Benefit Update Project. The legislature has funded a portion of the services on that prioritized list. And so certain things, there's a funding line and everything above the funding line gets covered. And the idea was that that funding line could move based upon things like the budget. However, the federal government has fixed that line for over a decade, so we haven't been able to change the funding. And so that has kept us from members losing any services. And at this point, that special waiver, as I said, is going to be ending at the end of 2026. So we're talking about that transition. How do we transition away from the prioritized list? So next slide, please. This is kind of a visual of what we just talked about. So it shows what has had an impact on the services in the Oregon Health Plan. At the top, you see the Centers for Medicaid and Medicare Services. That's the federal government. They're the federal agency that regulates the Medicaid program across the entire country. They determine some of the services that have to be included in every Medicaid health plan across the country. Excuse me. The Oregon Health Plan is the name of the Medicaid program in Oregon, as we said. And then you have the HERC here, the Health Evidence Review Commission. They review services and determine which ones should be in the Oregon Health Plan. And currently, what they do is they then put that on the prioritized list, listed in order of priority. So they're saying if you have this condition, we want you to go through these services in this order. Those services are then also outlined at a high level in the state plan. This is another kind of mechanism, the way that we organize things in our state. And that is a contract that we have with the federal government, with that Centers for Medicaid and Medicare Services to manage the Medicaid benefit in Oregon. So just another visual of the same information. Let's go to the next slide, please, and talk a little bit more about HERC, the Health Evidence Review Commission. So as I said, the HERC is a group of people that make most of the decisions in Oregon on what services should be included in the benefit package. The HERC has 13 members. They're appointed. They are physicians or other providers, sometimes people who represent the member, the Oregon Health Plan member perspective, and they make decisions about which services OHP will cover. The services that are chosen to be included are things that help prevent disease. They treat illnesses and injuries. They manage chronic conditions, and they have to improve a member's ability to function. HERC also produces something called a guideline note, and that is, it helps inform providers or CCOs about services that are medically necessary, for example. So it kind of gives more information about a service to say, here's the case in which you would use this or why. All of the HERC decisions are made in an open public forum where members, providers, and public participation is included and encouraged. And the HERC uses those public conversations. They look at evidence, they talk to providers, and they produce the prioritized list. And so as I said, that prioritized list is in order of importance to the Medicaid population. And then the legislature would then fund them according to what the budget permits. And for those of you who are more technically inclined, currently they cannot fund less than the current placement of the funding line, which is line 469 of the 660 lines total on the prioritized list. Okay, so next slide, please. Why did we have a prioritized list, or what exactly is that prioritized list? So, excuse me. As I said, OHA, or Oregon, has had the approval from the federal government to use this prioritized list idea since 1994. And the original goal of that list was to really say, let's get the most number of people covered by being strategic about which services we're covering. So if we can change the number of services covered, maybe more people could actually be covered. It's a great concept. However, the prioritized list isn't used as a budget tool anymore. That whole initial idea and concept hasn't been something we've actually been able to access and use. The federal government stopped our ability to use that budget mechanism since 2012, so it hasn't moved. In addition to that, 97% of people in Oregon now have health coverage. And so that initial idea of trying to maximize the number of people covered, we have less pressure on that because of how many people are covered in our state. It's a record high, which is a huge success for the state of Oregon. In addition, there were concerns, and there are concerns, that under the prioritized list, not all of what we consider mandatory benefits are covered. And so this transition of our benefit update project, transitioning and changing our organization of this, lets us have an opportunity to realign our benefit package with the federal requirements around mandatory benefits. So to summarize that, the list is not really working as the budgetary tool that it was envisioned to be. There's no longer the need for it in some of the ways that it was initially envisioned because of how many people in Oregon have healthcare coverage. And then we also need to comply with federal regulations that require OHP to cover services that CMS considers mandatory, which are not currently covered. So on the next slide, we're going to talk a little bit about why this is needed. So I shared a little bit about this, that things have functioned in a similar manner for 30 years. So why are we changing things now? As I said, we had this use of the prioritized list, this waiver, has been in effect for a long time, but that waiver is coming to an end at the end of 2026. And so we can't organize our benefits into a prioritized list with a funding line, which we've used of this like above the line, below the line. If things were below the line in this list of services, they would not be covered at all. And so really being able to say that that's not going to be how we organize things anymore, we have to change what that looks like. And so instead of that, Oregon will be moving to a typical organization of Medicaid benefits that most other states use. So next slide, please. Here's another picture to help us with anyone who's a visual learner, kind of comparing where we're at currently to where we'll be in the future. So as I stated, with this current structure, we have that Centers for Medicaid and Medicare Services. They're the federal agency that regulate Oregon's work, which is in purple. And then generally right now we have HERC in that yellowy orange box, making decisions about what goes into the Oregon Health Plan in order of importance to the Medicaid population. But if you look at the right-hand side and what will launch in 2027, in the future state, you'll see we still have CMS, we still have the Oregon Health Plan, we still have HERC, but instead of having a prioritized list, we will be organizing this through a state plan. OHA will be partnering with the HERC and really understanding with CCOs and providers to create a document that will make it clear for everyone about which services are covered and not covered, but the services won't be ranked in order like they are in the prioritized list. So it will be more in kind of like buckets or categories. And so as you can see, the changes that are occurring are really happening at a benefit organization level. It's largely considered administrative. We continue to emphasize that this shouldn't be a change for members. They'll really just see more things covered. But we want to make sure that providers and health plans and others are aware of this change to our structure. So let's talk about that future structure. Next slide, please. Could I get the next slide, please? Thank you, Maris. Okay, this is our future state. Starting January 1st, 2027. Oregon will be following the typical kind of the standard state plan. It's called a state plan amendment or a state plan structure that's required in federal regulations. The structure will divide our Medicaid benefit into two groupings: mandatory benefits. These are services like physician services, lab and x-ray, family planning, hospital care, things that are mandatory. States have to cover these services as long as it aligns with how the state determines something called medical necessity. And it's a specific technical term. And then there are optional benefits that the federal government says these are optional. So services like dental, chiropractic, physical therapy, occupational and speech therapy, prosthetics, those are optional. States don't have to cover them, and a state can limit them for budgetary reasons. And Oregon, for example, eyeglasses and some dental services for adults are not currently covered. Those are optional, and we've made a determination in Oregon based on budgetary reasons that these are not currently covered. And that'll be the structure of the state plan. So you'll have mandatory services and optional services with some flexibility. Okay, next slide, please. The benefit limitations. So all services that are delivered to Medicaid members must be considered medically necessary. And so, for example, you can't receive physical therapy if you don't have a medical condition that physical therapy would help improve. It has to be medically necessary for the condition that you currently have. Excuse me. Federal law allows states to limit mandatory benefits like doctors and hospital visits in a few ways. And so that, as I said, medical necessity, that the treatment has to be necessary to treat a medical condition, as well as something called utilization management. So maybe some services require a prior authorization before you can visit your health professional to make sure that that treatment is needed. So um, you go to a provider, the provider says, I think that this is needed. They send it to the CCO or to the insurance company and ask for prior authorization before you get that service to make sure that that treatment is needed. Every state gets to define its own medical necessity policy. In Oregon, most of the medical necessity policy is part of that HERC prioritized list. And we've talked about that as like funded or unfunded regions, or it's included in guideline notes. And the HERC has historically developed these policies by deciding specific codes to cover. So again, these are like super administrative. And then deciding which diagnosis code pairs with which treatment code. And so you have a diagnosis of a certain condition, and the HERC says, if you have that condition, here are the treatments that can go with it. And then additionally, they can create guideline notes that provide a little bit more context and background. So I'm going to do, I don't know if it's worth pausing, looking for a good place to pause for questions, but I think I'm just going to keep going for now. I know it's super dense and there's a lot of information, but let's go to the next slide and talk about the experience for members. So what is staying the same for members? As I said, a reminder, members will not lose benefits because of these changes. All the services covered today will still be covered on and after January 1st, 2027, unless there is new evidence that shows that a certain service is harmful or not effective. OHP will still not cover treatments that are cosmetic or are not medically necessary and appropriate, so that won't change. And OHA or the member's coordinated care organization may still need to approve some services. So for the most part, this is looking the same for most members. Next slide, please. So what is changing for members is that starting in January 2027, OHP will be covering medically necessary treatments for a small number of additional health conditions, things like fibromyalgia and nasal allergies, if a treatment is medically necessary and appropriate. Previously, these were below the funding line for conditions, and so they were not covered. So this is an example of the change happening, allowing for additional health conditions to be covered. There also will not be denials based solely on the funding line. Previously, if a provider said, I think this member needs this treatment, if that treatment was below the line on that prioritized list of services, it would be denied just because it was below the line. And so that is not going to happen anymore because we won't have a line. And so it has to be more specific to that member's needs and whether or not a CCO determines that's medically necessary in alignment with what the HERC has said. So there will also be, as part of that, a new process for member-initiated appeals for fee-for-service or open card. Excuse me. Next slide. So how are we actually getting to this future state? Let's talk a little bit about this transition planning. So this is the work that's currently being done in order to prepare for that transition from the prioritized list to this new benefit structure. So the HERC has a work plan for reviewing the services that are below the funding line. And I've seen a couple of questions that maybe this will help answer. So any services that are currently below the funding line that are not covered, HERC is going to be reviewing. And they will be doing this to ensure that anything that is mandatory and medically necessary is being covered. HERC will also be meeting with specialist providers to talk about medical necessity of services below the line. So what are those experiences of specialist providers? What have they seen in their treatment and their experiences? And HERC will also be relying on our definitions of medical necessity and medical appropriateness rules to make any policy changes. Just as a reminder, the HERC itself will not be making case-by-case decisions about services. They are looking at this from a population level about what is best for the Oregon Health Plan. They make the policies that then a CCO or fee-for-service and open card use to apply. They take the recommendations from the HERC and say, in this instance, this is what we would do for a member. And so the HERC is not responsible for the individual cases. They're really looking at this from this global kind of population level, what is best overall. And then the CCO or the fee-for-service program use those policies to make decisions. So next slide, a little bit of a recap. As I said, this is dense information, kind of recap of everything we've talked about today. So moving from a prioritized list organization towards this state plan organization and medical necessity decision-making. So currently we have conditions and treatments are ranked in priority order on that prioritized list. There's a funding line where everything above that funding line is funded and covered. Everything below the line is usually not covered. And medical necessity is defined by the diagnosis and treatment code pairings and guideline notes. In the future, starting January 1st, 2027, we're reorganizing these benefits into a state plan structure. And so a denial has to be based on medical necessity, not just a funding line. We're going to be using the CMS, the federal definitions of mandatory and optional services, to organize how we think about OHP benefits. And the HERC will continue to define which services are medically necessary. They'll be using code pairs and guideline notes. Next slide, please. So if you are someone who is really interested in this work and have input or want to be learning more, you can reach out to us with any coverage specific benefit questions and what's being reviewed by HERC. You can even offer suggestions. And so this is our email address that you can use. You can also email any other questions or comments to this topic, related to this topic, to our email address. We will be sharing updates on this benefit update project, as well as, where we're at with some of the review from the HERC and what the ongoing progress at reviewing those below the line topics. Sharing that at ALCOM and Para Todos meetings. We'll also be sharing it at the Medicaid Advisory Committee and through their Advancing Consumer Experience subcommittee meetings. HERC will continue to be holding community listening sessions, and their meetings are also public. So we encourage participation in that. And just want to encourage you, OHA is really going to be considering member input and public comments during this transition planning, which will be over the next year. And so please let your voice be heard. We really do encourage that. Next slide, please. If you are a provider or CCO and you're like, I got a lot to say here, we will also be holding specific sessions for you all, especially from that more technical workflow standpoint, operational changes. There's a listening session for providers on January 29th from 9 to 11 a.m. There's a registration link on this slide, but I am wondering if we can maybe put that in the chat for folks. And then there's also going to be a BUP operations work group for CCOs that will be launching this month. Excuse me. This is really to understand the changes that will be necessary that CCOs are anticipating to their workflows, to the appeals and grievances processes, understanding their input and feedback on what the HERC is reviewing as well. And this work group is going to occasionally be inviting providers to attend, depending on scheduled topics as well. Next slide, and I think this is my last slide on this topic. So these are just some links for how to participate in HERC. A link around the prioritized list that's currently searchable, links to the guideline notes, really if you want to dive deeper into how our current structures are. And then we have some web pages here on our benefit update project overall, including fact sheets and FAQs, frequently asked questions. So really appreciate that and appreciate your attention here. It's a really dense topic. But tell us, what you like, what you don't, what your concerns are, all of that we really appreciate. So I'm going to pause there and see, Jessica, if there's any questions in the chat that haven't been addressed yet, or if there's anything. I know we have Leah Forsman on, as well as some others from our staff who are helping lead this work.
Thank you so much. Goodness. And thank you, Satya, for posting the same thing I posted. My apologies there. Let's see here. We have a lot of really great questions. I'm not sure we have time to get to all of them.
Okay.
So I am wondering if there are questions around current benefits and adding new services, both more generally and then a specific call out to dental and eye care.
Great.
Maybe we can start there.
Sure. So questions about dental and eye care mandatory in Oregon, necessary for daily activities. These will be some of the conversations that the HERC will have as we shift to saying, okay, we can apply our own medical necessity criteria to these optional benefits. The budget still also impacts whether or not we can cover things, especially as we have such large expansions of the number of people who are covered generally. Oregon is one of the most comprehensive coverage states. So, it's pretty incredible, thorough benefit, but I know that there are always things that people are individually identifying need for. So those will be some of the topics that are discussed. They'll be applying that medical necessity criteria and then also looking at the budget for what dental and eye care from the federal government says that those are optional. And so Oregon will look at that specifically from an Oregon perspective. And that'll happen over the next year to year and a half as well. And so there's another question about whether or not this will limit flexibility or extend timeline to add new services as necessary. I don't really want to speculate on that, but I do believe that this will, just like there are constantly new services or new medications that are coming up, and the HERC will review them going forward the way that they have historically. And so those services, unless it changes from a federal side, is determined as something mandatory, the HERC will still follow their process of being able to absorb new services, which again, we've done historically, and as we get new services and pharmaceuticals that come out. Let's see.
And then I want to check in, Hannah, is your hand up on this on the same topic?
Pretty much. I wanted to talk about what she passed about the eye care, because I saw the question in the chat regarding that, and I remember the last time we met, I was talking about the IHS who we work with a lot here with the Native community. So that was the thing I was looking at about the eye care, because like I stated in our last meeting, that our eye care, because of our culture being a high risk of diabetes, um, I always think it's, important for our people to have eye care, consistent eye care, because again, like I said, we have a hereditary of diabetes. And as for myself and also elders and possibly children that have juvenile diabetes, constantly need our eyes checked every year. And again, after the age of 18 is where the cutoff date is for our for everybody for eye care. One of my priorities I wish it would be looked at is having this continual eye care, even for people with no diabetes. And I know that's a big area, because I'm not just talking about my native community, indigenous community, but also the other, cultures in our community that have the same disease as us. But ours is more progressive because again, it's genetic. And that's where I always think about is, where could we go? Where do we go for we go to IHS, but again, we have to come out of pocket. And these eye services are very expensive. And I know there's some areas like for us at the IHS, the Indian Health Service, which is called, or the Shamawa Clinic or Grand Ron, the federal clinics help us and alleviate that cost by not having it so high price. But still, this is one of my priorities of looking at you at OHA for how could we stop this? How could we start doing something, making change for our community that have diabetes and that need eye care on a yearly basis? Because, a lot of us can't afford eyeglasses, and a lot of the elders can't afford eyeglasses. So this is one of the things I think about right away when you guys talk about this new plans and what's going on. And that's going to hurt a big part of our community if some of these fundings are not allowed. Because again, I was hoping, maybe OHA and IHS need to come together and see how could you guys work together? Because again, we do have the open card, like you said, and most of our tribal people do have open cards that are not on a managed care. And where do we help our people? This is what my question will be to you guys. How could you help us to be, more healthier? Because again, this was brought on by genetics. So, but thank you.
Thank you so much for that, Hannah. And appreciate that. I mean, we do capture all of our feedback from this session as well and include it in our overall picture of what we're hearing from folks. We also have a couple of links in the chat about the HERC meetings. So just as an example, to talk about this a little bit more, next Monday at 8 a.m., they'll be meeting. And it's a webinar, and there's information about how to join. You could also go in person. And they take written public comment as well. Any written public comment that's received by a certain date will receive a response and be considered in preparing any final meeting materials. And so just as an example, they'll be going through specifically for the Benefit Update Project publicly, having conversations about a number of different topics, including services that are not effective in preventing disease, therapy for certain mental health conditions, fibromyalgia and chronic pain conditions, recommendations for treatments for conditions that cause long-term pain, treatments to repair finger injuries, eye conditions. So there's a number of topics that they go through, and they'll talk about the evidence, and they'll talk about what they're understanding and build towards recommendations over time in each of these areas. So encourage you to see that. If you have feedback on that, you can also share your feedback at that link or in person or at the email address that we have here as well.
What was that date again, Steph?
There's one on the 16th of January, so next Monday.
Okay.
And there is a meeting in the morning of a subcommittee that is a long meeting that's on that value-based benefits, all the things that I just listed. And then the HERC itself will meet later that day at 1:30 to talk about some of those topics as well.
I want
The
to
link is
check.
at that.
Thank you for that.
Oh, sorry.
Yeah.
Did not mean to interrupt. But I do see, Yvonne, you have a hand up and you have an unanswered question. So maybe that's the final question for this section, and then we'll carry on. Please go ahead.
Yes, thank you for taking my question. And this concern may not be warranted, but I wanted to just cover it just in case. So I'm curious if this transition, the removal of the prioritized list, might open the door for CCOs or provide some sort of loophole where then now they increase pending claims for providers to prove medical necessity. And so I have a concern about that because they wouldn't be denying claims. They would say, we're going to pen the claim. We need you to prove medical necessity. And then if providers maybe don't get all the paperwork there in time, and then don't meet those timelines, then a claim could ultimately be denied because the provider didn't follow through with what was requested of them by the CCO. I have a concern for that kind of activity maybe possibly happening.
Great. Thank you for that flag. I think, I mean, these types of concerns are helpful for us to understand what we should be looking for as we look at what the changes of these workflows will be on a CCO side. So really appreciate that flag. And we have a lot of staff on who are listening to this as well. And I think it's a great example of the type of thing that we just want to make sure we understand and that we don't unintentionally either support that or create any additional barriers for members in that case. So thanks for that.
Thank you.
Yeah. Okay. So I think we're going to move to the next topic because this was the dense one and we just want to make sure that we're getting through all the slides today. And as a reminder about another exciting topic. So next slide, please. We're going to shift to talk briefly about community capacity building funds again. And so we're going to provide a quick overview of the 2025 Community Capacity Building Funds grant program. So to begin with, as an overview, Community Capacity Building Funds, or CCBF, these are dollars that are provided as grants to organizations and providers who are actually offering the health-related social needs services. So these are housing, climate, outreach and engagement, and nutrition services that are part of that HRSN program. The funds are supporting organizations that either intend to become or are HRSN providers, and it's to help them get what they need in order to participate. So they may need additional workforce support or technology supports to be able to be an active provider. Just like last year, coordinated care organizations will be administering these dollars, and applications can be submitted between April and May, the end of May 2025. More information is available on our CCBF webpage. And we are just encouraging you all to, if you are an organization that may either be interested in becoming an HRSN provider or you are a provider and you've identified additional needs, then we encourage you to look at this. Next slide, please. As a reminder, there are 4 allowable uses for CCBF dollars. These were agreed upon between OHA and our federal agency, CMS. And so these are not just free use dollars. They have to be very specifically tied to these 4 topics. Technology. So an example here would be a new billing system that somebody wants to set up. Workforce development. So this could be salary or fringe benefits for up to 18 months. Allowing you to hire someone as you're getting ready to provide these services. Development of business practices, so designing new workflows and the time that it takes to do that. and then outreach and education. So perhaps launching a new learning collaborative or having certain signage changes, things like that. So just a note that workforce development funds, they are limited to 18 months. And CCBF dollars are not used for the actual services. So these are not used to support housing or rent. These are used for the organizations who help provide those services. Next slide, please. You may wonder if you are eligible for community capacity building funds. Excuse me. Next slide, please, Damaris. Thank you. So these are entities eligible to apply for and receive dollars. These are not the only ones, but just as examples. So community-based organizations like a housing agency or a food and nutrition provider. It could be an organization that provides or coordinates those health-related social needs benefits. So a case management provider or a local government agency, or an organization that supports development of the network. So maybe you're an organization that provides administrative or billing or training supports to HRSN providers. And so that's kind of like a convening or a hub capacity. So just a couple other notes. Tribal entities are also eligible to receive CCBF. They have a separate set-aside amount from the pool of funding available to other entities. And just to note that more information on this, including the very specific entities and organizations, are available on our webpage as well. Next slide is our timeline, and then I will pause for questions. So just as a reminder, so March through May, you'll see that outreach, engagement, technical assistance, application process is all live, April and May. And then in June and July, the CCOs will be reviewing those applications, and then OHA will get that just to make sure that we agree with the distribution, and we'll review and then go forth with distribution of the funds to the CCO, who will then disperse to the grantees. Okay, I'm going to pause there next, or actually we can go to the next slide and just pause on question and answer. There's a question about basically who is offering services. Those are provider networks that we are asking, and I don't know if anybody is on right now who can speak to this specifically. I don't remember what the requirements are for publicly sharing that. I believe CCOs are required to have that on their websites, but I don't know what the timeline is for that. Suzanne, do you know?
I do. Hi, Suzanne Cross, she, her, and pronouns. The CCOs will be required to publish who's approved on their website by the end of August when their funding is released and approved by OHA in the fall. And
we can share, there are right now on our website, if you go to the second, it says 2024 CCBF grants awarded by CCOs, and then there is a link about each CCO. Here, I'll pop it in the chat. Who received dollars. I think you're also maybe asking about generally who's a provider, and I think that's the question that I'm not sure I want to get back to you on and make sure I'm accurate on who's responsible for posting that information. I believe it is the CCO, but I'll see if someone else knows that.
Sorry, Steph, this is Lisa Kreis. I'm off camera because I'm not feeling well today, but what was the question? I can probably answer for you.
Thank you. What are the requirements for CCOs to be sharing their provider network broadly? Like, do they have to post on their website of who is an HRSN provider?
Who is the current HRSN provider? Okay, let me find that link. One sec.
Thank you.
Thanks.
Great. And then how much funding is being released this round? It'll be about the same as last round, which I believe was 38 million. For CBOs who are interested in applying, would they be expected to become an HRSN provider within a certain time period? That is something that your CCO can answer in the organization. That it depends on, you know, how close you are to being an HRSN provider, what the gaps are within the region. CCOs are really, and we're encouraging them to be transparent about this, but they are trying to build out their networks for what the needs are in their regions. And so that may vary in different regions in terms of what their needs are. And so they can work with you as a provider to figure out what the timeline may be for coming on board. Okay. And with that, I think we breezed through this. And I will turn it back to you, Jessica. Oh, Hannah, you have another question.
Yeah.
I see. Okay.
Thank you. Thank you again, ladies. I would like to know how Indigenous Now could become one of these providers for our community. Because again, we're trying to start our talking circles. And one of the things that was really crucial in that was spoken in our community, that was brought up to me through the community members, is these talking circles. So how could we, Indigenous Now, start the process on becoming one of these, to get one of these grant programs for our talking circles? Because again, this is a need in our community. And since OHP is having some of our traditional healing traditions, this is what I want to tap into, because it is a high need in our community. When you're having community members come to you in the community asking for these, this is what I listen to, because this is the community talking, not me. So this is why, how do we start this process to become one of these, to get the grant program, to become a provider for our community, to start doing these talking circles? Because again, we fairly became a nonprofit, where my goal is to start doing a lot of work in our community because of our healing, because of all of our generational trauma and all of our things that we've gone through in our history, in our culture. So this is why I attend these meetings, because I want to be part of this, so I could start reaching out to my community, so we could start healing and start working together, so that we can again, start working together, so we can start moving forward in our community. Because again, a lot of the things that get left out is, again, we got two Native communities, we got the local tribes, and then you got us other federally recognized tribes and our Indigenous communities. So remember that we're the unrepresented at this table. And this is why I bring, I may not have all of the knowledge and everything like you guys, but this is a start for me, so I could start doing something, because this is what I need for our community. When community members are coming to you asking for help, I don't sit back and wait for somebody else to do it. I do it myself, to get our voices to this table, to become and start healing ourselves as well. So I would like to, who do I go to? Who do I start with to come to this and start working on this type of grant program? Because again, looking at the your engagement and outreach, that's what we'll be doing. Because again, we have such a broad expansion of community members out here from all walks of tribes out here. So this is why I'm coming to the table, to learn about this and how to become part of this, to be part of this important part of our medical part, mainly for us, our mental part.
Yeah. Thank you so much, Hannah. I really appreciate that. It's so in keeping with what we are trying to do with this work and with the HRSN program, and really trying to look at folks more holistically, which it sounds like you're also focused on. So really appreciate that. What I would love is, I know you've shared this before, but if you could put your email address, you can either send it to everyone or just in a direct message to Jessica or myself. We'll make sure that our CCBF folks reach out to you, as well as our fee-for-service open card team, who can help think about how you fit in or where you fit in best with this work, especially recognizing that you are broader perhaps than just the federally recognized tribes in Oregon. So appreciate that. Thank you very much for sharing. And I know we're just about at time or over time. So if we can just go to the next 2 slides ahead, please. I'll just finish this out for you, Jessica.
Thank you.
And one more slide. Thank you. So we have some upcoming topics. We are starting to space these out a little bit more as we've launched a lot of these programs and we're in more of that operational phase. So our next meeting we'll be doing this quarterly. So April 9th will be the next topic, our next webinar, and then July 9th and October 8th. And if you go to the next slide, as always, we encourage you to stay connected with this work. You can use these email addresses. We triage everything. We're really on it. Grateful for all the work that folks do. We also have a web page, and then we have a newsletter that comes out as well. So thank you for all of that, and thank you for your ongoing partnership and collaboration. We really appreciate it, and thanks for hanging with us on this dense topic today.
Thank you all so much. And thank you, Steph. Oh, my goodness. And with a cold, you powered through. Thank you all. We're over time. So gonna maybe stay here for one more minute to capture anything else in the chat. But we are complete today and we will see you next quarter. Thank you all.